Clearly, this is a very popular talks, and thank you to the audience who've taken time off your busy days to come on an evening to listen to this talk. You'll be slightly surprised if I told you that it'll be a slightly different talk than what I have written there as an abstract, and there are various reasons. And nevertheless, I hope it will provide the sort of information which you would be interested in. I'll talk a lot from what we know from data. There are some things I may have left out, and you might ask me during the conversation, oh, there was this important thing you left out, and I'm happy to have a discussion about it. Some things I've left out on purpose, some things may be outside my field of normal expertise, and some things I may have left out because I wanted to focus on some solutions. So those are the various kind of background to the talk, but let me give you a declaration. I mean, why give this talk? Now, normally I'm working in the mood and anxiety program as a psychiatrist. A lot of my work is actually as a general psychiatrist, and I'm giving this talk more as a general psychiatrist. But the immediate sort of precedent for this talk, I mean, I've worked a lot in services like dialectical behavior therapy services, cognitive behavior therapy services, set up services in this area. But the immediate precedent for this talk was the several conversations I've had with people who self-harm. And it has become my convention to say to people, I apologize, I wish I could do more. And then one day it just struck me that, I think I can do more. And I thought I should give this talk. Because when you give a talk, like a conversation, there is an exchange of ideas. There might be some bright people here who will think of taking this work forward. There might be philanthropic donors who might say, okay, well, this is a good place for us to invest. So for various reasons, though I'm giving this talk, this is not a talk to show that we have expertise. This is a talk to say that maybe we should be doing something about this. Okay? And I will tell you what are the things which have been done and unfortunately have not actually yielded the results which we wanted. And what are the things which I think my best bets are which might yield results. Okay, so accidents will happen. Okay, accidents will happen. We probably will not be able to completely eliminate accidents, but interestingly, suicide is preventable. And I thought about this statement a lot. Why do people say suicide is preventable? Why do people say 0% rate? Because people generally have an intent to end their life, and there's somewhere there where that intent can be influenced. That's what we're saying when we're saying suicide is preventable. So it may seem like an idealistic notion, but the fact that humans can change their mind means that suicidal is preventable. So my talk will take a slightly different slant, a large-scale view and then more closer view. And it may even challenge some of the perceptions we professionals hold too. And consequently, the sort of things you hear from professionals and may have taken down as standard wisdom, you may challenge yourself with some of the startling data. This is a like suicide map of the world. Darker is worse, clearly, and lighter is better. And what's very interestingly, communism is certainly not good for health, as you can see, and mental health, morbidities, well-being, suicide rates generally is higher in previous communist countries. We also noticed that, well, Canada is kind of not the highest, but somewhere at a level where we should be concerned. And very interestingly, countries further south of us seem to have less of suicide, and those countries are actually generally poorer, where services are not as available. So, and yet they have less of suicide incidents. Some researchers have commented it depends on how they collect data and depends on various other things. I think we should not underestimate how people are collecting data. With globalizations, people are collecting pretty good data across the different countries. And just to mention that I have myself trained and worked in different countries. So it's very interesting data. So here's the well-being data. What do you think Canada's well-being ranking is? First, second, third, fourth, fifth. What's your guess? Be fun?
What's the top number?
So I said, like, what do you think? Can you give me a number, single digit to double digit, where Canada ranks in global well-being?
Single digit.
Single digit, yes, it's about fifth. Okay, so it's reasonably good ranking. How come that we have reasonably good ranking? At least you rank better than your neighbors. So darker is better in terms of well-being. So if you look at other countries, Australia, New Zealand, they also have fairly good rankings of well-being. And generally you'll see the highest ranking of well-being in countries in Northern Europe, and it's also been shown to be linked with income distribution. More income distribution, more well-being. That's been a known fact for a long period of time. So if those countries have large well-being ranking, there's some interesting data to see. So for instance, New Zealand has had an epidemic of suicides. Sweden, which has very good well-being ranking, has a lot of suicides. Japan has a lot of suicides, even though its well-being ranking is good. So suicide rates by themselves do not actually inform us about mental well-being. Even though we have traditionally linked suicide with mental disorders, suicide is not a good link, is not always a good indicator of the society's well-being. So it's much more complex phenomena than what we have been thinking. This is Canadian data, and clearly you'll see Nunavut is very high, and that's been a cause of concern for in the First Nation community as well. And we read about this. Actually, my friends write to me from other parts of the world expressing concern why this kind of disparity is there. Otherwise, Canadian ranking in suicide is not too bad in comparison to other countries in the world with similar economies. And some facts, and I don't want to sort of just this to be a statistical talk of facts. People actually do know a lot about these data. So we can see that on an average it's kind of coming to about 15 and about 100,000 on an average. That's coming on, maybe even less now than that in terms of the actual suicide data. So this is Ted Rogers Stadium in Toronto. It has a capacity of about 50 to 56,000. Now, if I asked you to imagine, we gave 15 people some unique t-shirts and asked you to find those people in a stadium twice that size over a period of, and they can go in and out of the stadium for the whole year. That's the kind of task we have in preventing suicide. So when you think your services are not responding enough, now remember, mental health services are largely underfunded across the world, not just in Canada. And if you ask people to select those 15 people who are likely to die every 100,000 population, it's a very hard job. It's a very hard job, almost impossible if we go by the traditional responses that we have. So clearly, the attempt rate is higher in women, but completion rate is high in men. People have been very alarmed by the fact that young people and suicide rates, and that's because young people tend not to die of other causes easily because they're generally healthy, they don't have other medical problems. So it's not like young people are dying at an alarming rate with suicide, it's just that young people don't have other health problems. The data on mental health is a very interesting data. That's because we have mainly data from Western European or countries which have connections with Western Europe, like Canada, US. I think when you look at Asian data from Asian countries, they have less link of suicide and mental health disorder, and that's because how they explain suicide is different from how we explain suicide here. It's probably to do with the conventions of diagnosing use of DSM that is showing very high rates of association between suicide and mental health. In other cultures, people have different explanations about suicide, and that's why we need more data from different places to think about this more clearly. However, depression indeed is probably one of the highest risk factors for suicide, and there's no denying that, and it doesn't matter where in the world, that is a very, very high risk factor for suicide. Whereas self-harm or deliberate self-harm or non-suicidal self-injury is a phenomena where the person is not intending to end their life, but does some self-harm for a particular purpose. Very often it's relief. And interestingly, I've found with quite a few of my clients over the years that they actually get some kind of a rush from it. So it could become enjoyable to actually self-harm. And in the early days of my career in the West, I saw young people who belonged to various subcultures like Goths, and for them, they actually had a whole ritual of how they have, the ritual and ranking and sharing of self-harm, and there were different cults and they were quite different from each other. And to really understand this, you have to understand the whole philosophy of that particular subgroup. It's not possible to estimate this accurately. Suicide is reported, investigated and reported, so we have much more accurate figures about suicide. We don't have very accurate figures about self-harm, but it may not be reported. And when I try to look at high-risk people who may be self-harming regularly and looked at hospital records, the problem was in the emergency room, people were coding it differently. So some doctors might just code it as laceration rather than self-harm. So this is another problem of why we can't go by routine hospital statistics. And if I remember, I will try and tell you what are the ways to actually enhance this detection itself in working with this population. And it's increasing in youth at an alarming rate, and that's been a concern. You've seen a lot of media coverage, and you can look at media coverage. This is probably a phenomena which is affecting the whole world, but you will see media in Western countries particularly showing increased self-harm in youth. So over the years, as you can see, that there's an increase in intentional self-harm. And you can say that a lot of that intentional self-harm is often when people get hospitalized, it's probably due to self-poisoning. Now, it's not that mental health is increasing at that, mental health disorders are increasing at that rapid rate, but self-harming is increasing. And this is why I'm saying that it's not so easily explained just by a mental health disorder. It's just the convention that we use of giving some diagnosis. You go to a hospital, you'll get a diagnosis. And when we try to interpret those diagnoses, it looks like everything can be explained by mental health disorder. And people may in one statistics I may not have very clearly put, because I don't want anyone to feel guilty. People would say, people with suicide have contacted health services in the last 3 months or last 2 weeks and spoken with someone in the last week. That puts the onus on somebody else to do something to prevent this fairly catastrophic event. And I think if we go by that sort of attribution, we'll only end up making people feel guilty for events over which they have no control at that point in time. And I will not try to explain it too much in detail and statistically, but the number of people who express intent, only a small percentage of those people are going to end their life. If you think of that Ted Rogers Stadium analogy, only 15 in 100,000. and maybe 500 or 1,000 may express intent, how do you, even with that number, sift out who will be the person who would take this serious step? Is social media a problem? Well, it's a problem and solution. There is clear-cut data from research to show that there's some kind of contagion effect. I mean, with social media, of course, people also remember movies like 13 Reasons Why, etc. So the world is becoming more and more interconnected by social media, and people are more likely to sort of model these behaviors because of social media. However, although not 100% proven, there is some promise of use of social media to reach out people. And we can talk about certain initiatives which are floating around, and initiatives which might happen here in our province, not entirely social media, but at least technology, to help with improving mental health for people. So there is definitely relationship between mental health and suicide. We can't deny that, but that doesn't explain everything about suicide. And I've already mentioned about that. So we have to think of other connections that suicide has. We have to think of suicide as a behavior, an intentful behavior, and look at other reasons which can contribute to it, to come up with effective treatments. Otherwise, we'll end up doing same old. We'll get money to do even more of the same old and not solve the problem effectively. So I'm going to present to you some very sensitive data. You know that the Inuit population has very high rate of suicides, and interestingly, has very high rate of suicides compared to other First Nation groups. But the depression rates are lower than Canadian average. How do you even explain that? Depression is one of those few, now you could say, well, depends on how you diagnose depression. It depends on whether people come forward for this diagnosis. So let me tell you some global facts. By now we've reached a level that across different cultures, we are able to diagnose depression very well. And there are a number of studies which have been done with cross-cultural incidents of depression. There are variations, but there are good tools and interview techniques to detect that. So here is clearly mental health not able to explain this sort of alarming figures. Let me show you some other. So here's some explanation. So you should look out for work by Amy Bombay, who is a very young person doing a lot of research in this area, very hallmark research, and I expect to see more coming out of her. I think she's working in Dalhousie University and is part of large networks. And she's a second author here, but look at the effect of intergenerational trauma. So what I'm trying to say here is that the reasons for suicide in one community, like this community, is going to be quite different from somebody who commits suicide, say, in inner city, Ottawa or Toronto. Ottawa, does it have an inner city? Toronto has an inner city. So Ottawa has an inner city, okay. So the causes will be different, and that's how our strategies have to be necessarily different. And we may have to come up with strategies even when we do not know the causes very well. And look at this data. They looked at the economic data. Clearly, as the economy increased, people said, okay, is this the increase in economy, or is it the increase in stock market? So economic increase is actual economic productivity, what the nation produces, versus stock market. Stock market is like fake increase in economy. You can't measure that. So the fake increase in economy doesn't seem to do much to sort of people's mental health. But the real increase in economy seems to decrease suicide. The next one is even more interesting because that's data from 29 European countries. And clearly there is a link with the economy there. But I couldn't understand why men grew more suicidal when prices went up and women became less suicidal when prices went up. That's really hard to explain, and this is very large scale data so I don't know. Anyone's got any explanations for that? So strange, right? So we have lots and lots of interesting data to digest, to understand what are the different factors which affect suicide rate. Climate has also been linked with suicide rates, but they are not like huge factors, but they do add to the overall effect in influencing suicide rates. So if you think of the football or the sports stadium analogy, just going with that kind of a large net is not going to get us to the vulnerable people that easily. We probably have to be very focused on who we direct the intervention to begin with, and that's kind of a more high risk strategy, as in looking at people who are most likely, statistically most likely, to go down this road and try to do interventions with them. And guess what? Within the criminal justice system, prison population, the prison suicide rates are even higher than what you were seeing in the province of Nunavut. These are some other risk factors. One of the problem with these risk factors is that lots of people would have it, and they are not so sort of concrete. For example, people may report history of trauma, but you cannot do intervention straight away for preventing suicide just because people have history of trauma. So it's very hard to actually operationalize an approach to intervene and keep that person safety improving over a period of time. I've put in a lot more details. So this is a slide from UK actually. Social isolation is going to be is already becoming an epidemic, especially in the senior age group. And guess what? Social isolation affects health more than exercise. So it's one of the highest factors affecting health and longevity, and that's also been associated with suicide. So in certain populations, perhaps people who are growing older, social isolation might be the target for suicide reduction or mental health improvement, or indeed health improvement. So as I said, we may not know all the causes, but we still must find solutions. So if we use the football stadium analogy, so that's a large football stadium, and detecting 7 people out of those 50,000 or 15 people or 100,000 is going to be really hard. So we might have to use a different strategy, which is what I alluded to before, a high-risk strategy. And within the high-risk strategy, we can think of 2 sort of major arms. One is long-term prevention, and second is immediate risk reduction. By and large, I find that the immediate risk reduction is not so well developed in Canada. It's the longer term prevention, well-being seems to be much better well developed than the immediate risk reduction, and there might be various reasons for it, and we have to sort of ask ourselves why. The immediate risk reduction strategy would be for people who are persistently talking about self-harm, presenting with self-harm, attempting suicide, and we are still not doing a rapid enough strategy to help those people, because that's our best chance, because it's right at the face. And for healthcare systems, certainly that is, or clinicians, that is probably the highest value approach. As I told you, my talk is going to be a little bit different from what I intended to do, because I felt that I should give you a broader overview, given that the colleagues I wanted to have are not here, so I thought I'd give you that overview. So in terms of preventions, well, men are lovable and vulnerable. That's my line of the day. Okay, so you have to think of men. And look, they get upset when prices go up too. So as a man, the message to you is, when prices go up, wait for it to appear in winners. It always comes there. Okay, so So men, there has, and the Movember project has been an incredible project. I know people who've been working in it, and I also read some of the transcripts of what people are coming up with, and it's really interesting because men aren't really, they don't connect very well, and that's one of the issues of life expectancy, and as men grow older, that we have to actually teach men to keep connecting with people. Have people heard of men's sheds? Okay. Yes. Okay. Yeah. Some of you have heard, and it's a very interesting idea from Australia, and it's kind of taking root in many places. They are there in Canada too. I'm not so sure how they've been structured. So typically in a men's shed, well, men get together and do various things, but they also have mental health coaches to help with things. So for this high risk population, so men I had some difficulty selecting these photos because ideally with the men's shed project we should target men who are before their 50s because that's the highest risk group amongst men. So you should really encourage even younger men to be part of some kind of connection. And they have mental health coaches as well associated with men's shed who can work with people at that term. So this is a very interesting project, and a lot of that has been going on in the UK too. Within the literature, the one which keeps coming up as having so the literature is not so good in this area of how to prevent suicides in Indigenous people. There's not a huge amount of research. A lot of research sometimes becomes qualitative, so it's difficult to actually draw conclusions. But this is one of the areas which has shown some promise, having Indigenous gatekeepers who understand the community. So gatekeepers are not really closing the gates, they're opening the gates. That's the concept. Sometimes gatekeeper may mean actually standing at the gate and not letting you come in. But this is the opposite. This is people who open the gates. So they have connections in the community, formal and informal. They find out who is struggling, who is high risk, and they establish networks and connections to intervene. So again, a very different model from say men's shed, but depending on the group we are working with, we'll have to slightly modify the type of model we are using. I'm not going to talk about prison mental health services because that's not my expertise. Prison mental health service is not exactly the same as forensic mental health. That's slightly different. But generally people who work in forensic mental health work in prison mental health services. And this is a huge area. And there are some semantics which I find different, amusingly different between countries and cultures. I did not know that prisons were called correctional services. I found this word correctional very strange because the general European attitude towards prison is it's a place for rehabilitating people, even though we use it. So it's kind of rehabilitating people. Even if you see in Northern European countries, people actually finish academic degrees and whatnot and get professions, jobs, etc. whilst they're in prison. In fact, they have had to, in certain Northern European countries, shut down prisons because there are not enough people to put into prisons. So prisons are almost like rehab and educational institutions, and that's where people would probably, improve their lot in life better. And I think just providing health services is not going to change the outcome to what happens in this. So that's kind of my take on this, looking at how internationally people have dealt with these issues. So I was even more alarmed at the number of people who are in prison in US, and probably your highest mental health population density will be in prisons in US, or mental health disorder population. This is one of the most well-documented and evidence-based intervention, reducing access to means of self-harm. So in US, if they just reduced access to, for instance, firearms, it would reduce drastically suicide due to firearms. I am not so sure, I've not been in Canada for so long, but in UK they had, and many other countries, they reduced the size of acetaminophen called paracetamol in UK and elsewhere, the size of the package, and that reduced the presentation of overdoses with this in emergency rooms. So 2-3 years down the line, when they looked at this kind of simple measure, it had, and my colleagues who were involved with this said that they had to go for many discussions, debates, arguments to actually achieve this, but it was worthwhile. So these are some measures which are very effective and can be done at a very large scale. Interestingly, well, I have 2 risk factors, male and being in medicine. Suicide is occupational hazard in certain professions, and part of it could just be the access and means and knowledge of the method. And Andre Picard, who usually has to say something fiery, talks about this, and especially refers to the fact that 400 doctors in US die every year with suicide. That's an alarming rate. But also farmers, because they have access to means, but also farmers are very much affected by economic cycles, and there's clear link between suicide and economic cycles. So if we see an economic downturn coming, there are certain professions we should be intervening more. So this is what I mean by not devising interventions just blindly, just thinking about mental health disorders, but thinking about the various other factors which might influence suicide rates.
Like the psychiatrists.
Psychiatrists, yes. Thank you. Therefore, my interest. And youth and children, there is cause for alarm. I think it's what I found over the years that I practiced psychiatry in different countries is the normalization of self-harm, which has happened. So it's a normal way of coping, and people hear about it, see it in websites, see it in social media, and there seems to be sort of more of a copycat approach happening with this. People have tried various strategies. It's alarmingly resistant to any strategy. So people have tried social media strategies, school health education strategies. Probably school health education works much better for mental health, but not as good for self-harm reduction. And then there are special populations. So perinatal women around the time of childbirth, they strangely report more suicidal ideation, and women in those years are also more prone to depression. Depression and suicide in women has a much higher impact in children than say any other loss. In fact, they become more prone to suicide in the future themselves. And sometimes when I'm working with clients who are suicidal, I'm trying to help them think about the future beyond the suicide time horizon and how many people might be affected and influenced by them not being in their life. We are only beginning to learn about other populations like LGBTQ, and this is particularly a problem in young people who are just kind of getting their bearings with this identity and transition. And they don't have all the sort of mature understanding of themselves as people, persons. So they at that time is a very critical phase when they are at a higher risk. So as they grow older, in any case, society is changing and there's more acceptance, more methods to acknowledge this. Plus, as people grow older, they become more sure of themselves. Then they are at slightly lower risk. But in their early years, they are at a higher risk. If we look at mental health disorders, the biggest place to intervene is depression, simply because it's just more common than other disorders. So if we improve the outcomes in depression, and I have to say, I don't know whether I should say it with a sense of defeat or not, despite the fact that we've had so much campaign about treatment of depression, a lot of resources into treatment of depression, the depression rates themselves haven't come down, and we have to rethink what is going on in the way that we are doing things. But those are the two other diagnoses where suicide is a big risk factor. Any mental health disorder increases risk of suicide, but I just didn't want to list all of them. I just wanted to look at the ones which are the biggest, which should be the biggest targets. People with anxiety also self-harm. I've seen a lot of young people, college and university students who self-harm when they develop anxiety. So if we look at different approaches and we think of outside the hospital first, because that's where most people are. So that's primary care or population. What absolutely does not work is going around screening people and asking them if they're depressed. There's data to show that even if you train family physicians to do this, nothing comes out of it. And the reason for this is very simple. After asking them, if we don't say what we can do about it, what's the point of even asking the question? So actually this is not recommended anymore as a strategy, routinely screening people. And interestingly, we have, although we don't routinely screen people, perhaps unless we do targeted screening. So for instance, I would definitely recommend screening for depression in, say, chronic conditions like chest diseases, diabetes, because mental health and the physical health together is a very, very high risk for suicide. So those are the areas where we should screen and intervene early. So what should we do? I told you a little bit about what should we do. And screening, the correct answer is that we have to treat depression better and sooner. Okay? And if you're thinking of this, you get full marks. But here's the thing. Sooner, faster, for those people who were around in the 90s or who were around and very conscious in the 90s, some of you may have been very young, we had the decade of the brain and we thought we'll understand everything about the brain. It was also the decade of the Prozac. So people remember the Prozac Nation, the Times headline. And we thought we have cracked the problem of depression. Now, there is and this is not just Ontario data, there is antidepressant in water now. So just like there's fluoride in water, which is good for your teeth, if antidepressant in water was so good that even the fishes, we haven't seen happy fishes either. So it's not like antidepressants have changed the way, have changed the level of depression, and they have certainly not at a population level reduced suicide. So that's alarming. So here's my sort of, my declaration of interest. I am interested in this area, but the reality is there is a lot of health economic data to show that if we intervene with psychological therapies earlier for depression in a systematic way, we can actually at least reduce the economic burden of mental health in the society and hopefully reduce things like risk of suicide. Because when you provide psychological intervention, you actually empower people to look better after themselves, to be more independent in looking better after themselves. So you're not just a passive recipient of a pill, and I'm not against giving people pills. Half my job is doing that. But it actually gives people skills to live their life. And many of my colleagues whom I worked with in the UK, they're actually not even calling it psychological therapies, they're calling it all sorts of things. And here's a plug-in for one of our projects here at the Institute of Mental Health Research. We recently, a big team of ours, and I'm a very small part of that, won a hackathon. And instead of calling it psychological therapy, they called it depression in workplace intervention. They called it hard hat, to protect your mind. So, there are different ways to actually, and we had designers and coders who came up with this concept, which frankly we couldn't have thought of. We would have said cognitive behavior therapy or something else boring. Okay, so, but when it comes to hospital care, certainly increasing access to psychological therapy is very important, and all I can tell you that the federal government and the provincial government is looking at it very seriously, and I'm really optimistic about this, and I hope that you will see that soon, sometime in the future. So we have to start thinking seriously about psychological therapies for self-harm. We are thinking very seriously about psychological therapies for depression and anxiety, but we have to think even more seriously about psychological therapies for self-harm. in this kind of picture, I'm trying to tell you all the different things I've seen across the world of things which have worked. And we have to think of not just provide. I was very surprised that in North America, the model is outpatient care. You come to the hospital, go to the outpatient, get admitted, get discharged. And then there was community care, so the CMHA does a very good job of care in the community. But then everything is based on the hospital refers to a community agency, and a lot of time I spend a lot of time doing these things, and I'm lucky now to have very good colleagues in different agencies. They respond very quickly, but it should just be automatic. So we need to have care navigators for everyone who gets into a specialist or secondary care upwards mental health services, so that they can, because mental health care is not just pills and psychological therapy, it's navigating jobs, relationships, housing, all those things which are as important and which might reduce stress in people's lives and improve outcomes. So everyone, in my previous jobs in UK, every person in mental health care had a care navigator. Isn't that a great thing? Yes. And the government put a lot of money in providing care coordinators. So even before I saw a person, the care navigator was first in place before they had a doctor. And the care navigator actually prepared all the information before we sat and reviewed what to do next. Your care is very much focused on that one professional who's going to take all the decisions. And clearly that's not the case, because my experience in housing is not enormous. I mean, over years I have tried to pick up a few things, but clearly a team with care navigator would be so much better. And the care navigator then does post-discharge care too. So even before discharge, the care navigator, who's the constant, will help to actually look at, and the reason I mentioned post-discharge care, because that's yet another high-risk period for suicide, again, something really preventable. And if you look at the data from Ontario, let's say Toronto, which has the highest per head population of psychiatrists that I've ever seen, by the way, second highest would be Ottawa. It takes a long time to get people an appointment with a psychiatrist or a doctor post-discharge. Again, preventable. I have a friend who said to me, I was printing out a list of psychiatrists who's in Toronto, and he said, my printer ran out of paper. So it's amazing, isn't it? And yet we can't find follow-up care easily. So post-discharge care, but if you had a care navigator, they would be able to negotiate these things very quickly. I can tell you wonderful stories about care navigation, but that's a kind of a talk in itself. I actually saw a TED talk about this from US about 2-3 years ago, and I was surprised it was actually a TED talk. This is what people have been doing in Europe for more than a decade. So crisis and home treatment team, it's not the same as mobile crisis team. People are very much used to mobile crisis team. It's a different model. The crisis and home treatment team model comes from Australia, and it was implemented across many European countries, particularly in the National Health Service in UK. Crisis teams are in UK and Australia. They are aware of beds, they are aware of community resources, they go to people's homes, and in the initial period of their contact with health services, for the first few weeks, they will provide all the interventions. And it was amazing. Like when I used to be on call, the crisis team did everything, 24 hours a day. And they would tell me where exactly beds. I don't have to ring up, find out, talk to the social workers, where beds are available, all that stuff, which is really a lot of waste of time. So crisis and home treatment team have been really immense advances, and there have been data to show that over time, they may have reduced at least incidents of self-harm. So that's another amazing thing which we can replicate easily here. So I'm coming to sort of the bigger selling points of my speech. I think what's right in the front of us is what we should absolutely act on, which is self-harm. And I have heard many of these things across countries. Like people say, cry for help. For me, well, it's already in the risk zone. I don't even know where the person is crying for help, because for some people, self-harm could be pleasurable, might provide relief, might give a buzz. So I don't know. I want to use straight away self-harm equals risk. And we have to do something to reduce the risk. I've heard very derogatory terms by professionals who would say, oh, this is just attention seeking. Well, attention seeking or not, I'm going to talk, I'm perhaps attention seeking or not, it's high risk behavior. So we have to stop using these terms because they mean nothing. Okay, sorry. I think I do go into a rant now and then.
You're allowed.
Okay. So hospitalization is not a systematic solution. Okay. And I have been blamed, accused, harassed so many times about this comment because really in people's mind, hospitalization is the answer to self-harm and suicide, and it's not. And I will describe some of my experiences as I go forward. So let's look at closer clinical look. So hospitalization does not, in the longer term, reduce risk of suicide or self-harm. Only in the short term. So when you look at patterns of self-harm, when people are depressed, I look at a lot of referrals. I say people are depressed, they won't have high frequency of self-harm. When somebody is depressed, feeling hopeless, has low energy, they do not have energy to repeatedly self-harm. So they're going to plan, and they have less self-harm attempt, which will be like higher risk attempts. That's why depression has one of the highest self-harm, suicide risks. Okay. Whereas when people have personality disorders, they're distressed in a different way, and they'll try to alleviate the distress by self-harming. So they have multiple repetition of self-harm, and just looking at that through health records, we should identify which direction this is going to head and have different strategies for that. Okay, very easy. You can look at the charts and come up with this very easy. Most experienced mental health professionals actually are able to read this easily, and then we kind of direct them to different directions. Okay, but not everybody who self-harms may have a mental health diagnosis like these. I see a lot of young people who self-harm. It's an expression of distress in their stage in life, but they may not have a mental health diagnosis. However, they're increasing their risk. So irrespective of the diagnosis, once you've self-harmed, you're more likely to self-harm. Human beings have a normal inhibition to harm themselves. And once you have broken the inhibition, you're more likely to break it again. I also looked at animal data to see, do we have an animal model? In one time in my life, I did research on animal models. We actually don't have animal models of self-harm. So interestingly, self-harm is associated with thinking, right? And animals, I think, don't think very deeply, and therefore they don't self-harm. Okay? So we were looking at some prevention, and now we're moving. The lines are not so divided, but we're now moving into interventions. So these are the therapies, and I'm trained in some of them, not all of them. And the reason I emphasize this is after being a cognitive behavior therapist for many years, I thought, I keep meeting, especially young girls who are self-harming, and I felt completely out of depth, particularly because I hadn't even grown up in the West, so it was difficult for me to understand, a young girl who comes to my clinic with a lot of tattoos and who shows me her diary in blood. So these are the sort of things which I just thought I needed to do something. So I went and trained in dialectical behavior therapy and some of the other therapies there. And what's interesting was, not only did my understanding increase, my interest to work in that area increased. So here's a case where I think we can help people become more empathic if we train them to work with certain populations more specifically. So my interest, my hope, my empathy with this group increased because I found that, there are ways in which we can help these people. So I'll give you some of my examples, mainly service level examples and maybe some case examples. So in dialectical behavior therapy, the thinking is that people are having extremes of emotions, extremes of views. This is a kind of a very cut down version. And when people are having that in borderline personality disorder, standard CBT doesn't work. Standard CBT deals with one emotion, depression, anxiety, trauma flashbacks, those sort of things. But when you are going all over the place with different intense emotions, CBT is not so effective. And dialectical behavior therapy has been devised to actually navigate those extreme poles of behaviors and bring people a little bit more centered through things like mindfulness, etc. Dialectical behavior therapy also says there's no point giving therapy to people when they're struggling day to day with their skills of living life. So that's why they have separate skills program. They have one-to-one therapy, and then for the users of this program, they have telephone coaching. I don't think there's a full dialectical therapy program in Ottawa. You'll be surprised to hear that, because all those three components and the telephone coaching has to be available 24 hours. So people need coaching when they're suicidal or about to self-harm. What's the point of waiting for your therapy session to find out what you could have done different? Okay, so dialectical behavior is amazing, and when I really struggled to learn this, because it was very different from what I had done before. But it was amazing that I'll give you two examples. So there was a lady who was, who had repeated self-harm, had been diagnosed with various personality disorders, post-traumatic stress disorder, eating disorder, you name it. I mean, sometimes you actually are surprised that people are somehow managing to live. And multiple personalities as well, and I might have forgotten a few other things. And I just thought when I first met this person that I thought I don't know, I was unsure whether I'll be able to do anything. But over a period of time, the self-harm went down dramatically, and sometimes I had to work because of the multiple personalities. I had to sometimes see different people in session. And over a period of time, it reduced. Telephone coaching was very effective. And that person, actually I was surprised, when we were doing skills training, that person became a resource for other people. And I've seen that happen many times in dialectical behavior therapy, that the severest self-harmers, and they would, in the first cycle, be like your troublemakers in a classroom. But by the second 6 months and the third 6 months, they're the people who are providing support to a lot of other people who are just beginning their therapy program. So I saw many amazing examples like that, which really changed my mind about this. At that time, I was at least 1.5 decades younger, and I thought, this business of sitting and waiting for referrals seems very strange, because people are self-harming all over the place. And then we set up a hospital or some kind of system to seek referrals. So we devised an innovative program where instead of waiting for referrals, we just went to emergency rooms, and whether we had electronic medical record or not, I'll tell you, emergency room physicians and nurses, they're amazing. They know all the names of people who come regularly to emergency rooms. They'll tell you, oh yes, I hope nobody's name is Amy. Amy comes to every week with this or that. So they actually know. And so we started picking the highest presenters and said, okay, we have a service for the highest presenters with self-harm, rather than we have a service, please refer when you have time. So we just set up this service, and it was amazing because the emergency room people started telling me that these people we don't see them that often. And in many other places, we have actually specialized nurses who just do self-harm work. So they actually know these people even well, and they start telling me that we don't see them. So this was a full dialectical behavior therapy service, and within a year, I was paying back with dramatic reductions in emergency room presentations. I did somewhat similar in Nova Scotia when I was working there, again out of frustration. What's interesting is I just had two. One was me and another person who was very fresh off school, and we set up this program. We may have taken about 10-15 people who presented repeatedly to the emergency rooms. And by the way, in Nova Scotia, everybody knows about everybody's life, so they come and tell you everything about those people. So they start telling me, oh, she looks different, or she's not been coming to the emergency room. The receptionist would tell me, but I've known this person for years. So, at that level, going actively looking for people who are experiencing this and taking the highest risk ones and intervening seems to be absolutely proven in my mind to work. So cognitive behavior therapy and problem solving therapies, these didn't have as much evidence earlier on, say maybe in 90s and 2000s, and many trials failed. And I think the reason they failed is they didn't focus the therapy on the issue. If your focus becomes too large, like let's understand all your life, you'll not do effective work with self-harm. You really need to focus on the immediate risk, what's driving that, and how to contain that first before looking into the rest of people's lives. And I think the initial packages of cognitive behavior therapy were too broad and they didn't succeed at all. They were very negative trials, and this is why I actually went to learn some other therapies. But now there's more hope. Cognitive behavior therapy and problem solving therapies, and if one of my colleagues, Dr. Hatcher, was here, he would talk about that too. And my other colleague who I'd approached was Dr. Mercer, who runs an excellent DBT program in Canadian Mental Health Association. So just to mention that these are some people who are really valuable resources in this city. So Dr. Hatcher's research showed that if you take people who are at the higher level of the self-harm spectrum, we can probably make a difference in reducing the self-harm. The problem is if you say, okay, please refer patients to us, often people refer patients who are not actually at the higher end of the spectrum. And then what happens is, if I'm running a DBT group, I have this really high functioning person who thinks about self-harm, and then I have this really struggling person who self-harms every week. That person will keep quiet because they feel so underconfident to speak because so many people who seem to be confident and outspoken. So I actually look for groups where people are really struggling because I know that's the group which is going to make most progress. Okay. So problem solving therapy is also a very good advancement, very, very simple way of dealing with things. When people are depressed, the problem solving therapists will not ask about your mind, thoughts, behaviors. They'll ask you, what is the thing you're struggling with most, and go about systematically to see how you could work through that. Now, that's also included as a part of CBT, but problem solving therapists mainly do that. Very simple intervention to learn, teach, and practice. And that could be yet another effective way of targeting people with self-harm. I would keep problem solving therapies not so much for people with borderline personality disorders. For borderline personality disorders, I would choose more of dialectical behavior therapy approach. There are many other effective therapies, and I have less experience with them. Mentalization-based therapy is helping people understand the effect they have on other people. This is used with borderline personality disorder, not so available in Canada, I think. And over the years, the data has increased a lot to say that, okay, this is one of the therapies we should be offering people with borderline personality disorder and self-harm. And we are really lagging behind there here in this city. We probably need to have these services more because this is kind of the highest risk, one of the highest risk group. Transference-focused therapy is a psychodynamic therapy, and I have even less hands-on experience with that. But they've done some very good trials to show that the relationship between the therapist and the client, which is a very intense relationship, by interpreting those nuances, you can help people manage their life better in terms of dealing with other people. And of course, schema-focused therapy, where I have some more knowledge, is looking at how people right on very early on in their life might have set patterns of thinking, feeling, behavior, which may be setting them up throughout. So whereas in the traditional cognitive therapy, you think that people's patterns get triggered later on in life, they're all latent. In schema-focused therapy, you think that these patterns are not dormant, they're always playing right from the beginning of the person's life. And we can see that a lot. It has an incredible array of techniques to use with this clientele. Again, not so available in Canada. I just want to emphasize, in case I haven't emphasized enough, the thing which we need to focus a lot on is fidelity in how these therapies are practiced. So going for a weekend workshop or even a week-long workshop, or even gathering together as a group of interested people is not enough. You really have to do gold standard training and supervision and have your work analyzed, criticized to actually achieve high level of competence in these therapies. And that's something which we are really trying very hard to espouse across the province. So bereavement due to suicide is hard because it's one of the biggest loss a person can have, particularly if it's a child. And bereaved people are at a high risk. So here is another population which is at high risk. It's very obvious they're at high risk. Interventions for this, and interventions we should not just rest on only peer support. We should be at a point where we should be providing specialized interventions to this people, because this is a very high risk group. There are many other ways to improve protective factors. I find work as a very significantly protective factor, and my declaration of interest is that is one of my areas of research. I found work and education very, very important, and so I've seen so many successes of people. I had a patient 2 years ago, or 1.5 years ago, who's come and nothing seemed to be right in life. Nothing at all seemed to be right in life. And we talked about work, and he was kind of, working on the black a little bit here and there. And I said, that's better than not working. We started discussing about things, and one day he came back to me, and he was very well dressed with a briefcase. He had his portfolio. I think he was doing some kind of construction stuff. And this is the person where I used to feel hopeless in the session very often. And he said, for some reason, on one day it struck him that things are not so badly off. He started looking for work, went back to work, but he started volunteering in, I think, helping disadvantaged children. And his life just changed. And he actually sought discharge. Somehow self-corrected it. This person had not a single friend in this country. He was at that level. He was just living in some kind of boarding house. And so when I mean work and occupation, I don't necessarily mean just being employed, but volunteering in other contexts as well. Decreasing isolation is going to be a very, very, very important approach in healthcare for the future. I've seen and heard architects who are actually devising housing, like some of the kind of middle class housing we have with large yards and whatnot, which people aspire to, actually increase isolation. So what are you going to do in those houses when you can't see your neighbors across easily? Okay, so isolation is going to be a health intervention. Exercise reduces self-harm thinking, and treating chronic physical condition, and this will come around. When I was in UK, I used to work as what is known as consultation liaison psychiatrist, and the funding was drying out in that area. So a lot of my work was working with chronically physically ill and mental health issues. And the numbers were dwindling. And then suddenly the government found out that it's really great investment to treat mental illnesses in people with chronic physical health problems, because it reduces hospital rates, it reduces cost of care, it reduces all sorts of things. So they started investing a lot of money, and there are very, very good reports to show why, if we target this group, it's going to be very beneficial for the healthcare economy. I didn't want to talk about it, but I thought people might ask me. Okay, lithium and clozapine are the only medications known to reduce suicide and suicide attempts. I was wondering whether people will ask me about ketamine, because we have ketamine studies here and a lot of people are interested. Yes, it reduces suicidal thinking. We don't know whether it reduces suicide. And ketamine action is usually 1 to 2 weeks. We don't know what happens after that. So a lot of promise, but we still have to wait for research. We can't just jump in the bandwagon and say, let's try this because this is the answer. Some of my other things which I gave you are bigger answers than this. So lithium data is interesting. The level of suicide rate has also been correlated with how much lithium there is in the water. I thought people may ask this, that's why I'm touching on this. Do antidepressants cause suicide, suicidality? The data is not so clear. We need to be cautious with children and youth. and not try to choose them as first-line strategies. In fact, in youth and young people, if we are seeing depression, we should try psychological treatments first rather than medications. But the thing with antidepressant, though, they might overall reduce suicide because they treat depression. So we shouldn't go off antidepressants completely. But we should be watchful in the initial days. And one of my practice used to be that I provide people like telephone contact if I start them on new antidepressants, and within few days, or a team worker could do that, pharmacists could do that, and that may help us monitor these things early on. So if we think of a kind of, I'm coming towards the end of my talk, a trajectory approach in terms of prevention and intervention. Pregnancy is a very crucial, pregnancy and new mothers is a very, very vulnerable group, and that's where a lot of mental health intervention should go, because it's actually good for the child. It's good for the long-term future of the child. In childhood, managing childhood adversity is important. People are very focused on trauma. The bigger challenge is not trauma, but socio-demographics, the deprivation, because deprivation is actually linked to trauma. So if we manage to deal with deprivation, the incidence of trauma will come down. In teen years, certainly we should think, especially teens who are going into more minority identities like LGBTQ, etc., they are a high-risk population. We should definitely pay more attention to them because they're just beginning to navigate a world with very different identities from other people. Young adulthood onwards, gender, males are at a higher risk, and we've talked about certain interventions which can target males. Employment and relationships are important. Now, we have to think of custom device solutions for different groups, like we talked about First Nations, and the standard things which we're doing in one place may not work in another place. So we may have to customize things through different service designs and access designs. And in senior years, my top bet would be isolation. I mean, physical health deterioration and health problems are a given. I mean, it's going to happen. The body is just designed that way. But isolation is something that we can definitely do something about. So what now? So I've given you sort of a whirlwind tour, but what should we be doing now? So I've kind of put a set of questions, because where do you think we can easily find people who are self-harm? Because to me, self-harm is, the clearest risk factor, a detectable risk factor. So where do we find a lot of people with self-harm? High schools? Good. College? On the streets? Okay, on the streets. Elementary schools, okay. I would have argued hospitals too, emergency rooms. People turn up to the emergency rooms. Yes?
In their homes.
Upon?
In their homes.
I couldn't, in there?
In their homes.
Well, how will you find high density of those people? Of course, in homes you'll find them. So think of, okay, there might be certain types of homes where you might find them.
Shelters.
Okay, shelters, yes, yeah. Okay, so you can devise interventions by actually not waiting for people to come to a particular service. So putting up a shingle and a board, I think we all do that, is not the way to solve these problems. We have to actually proactively devise a conduit into those areas and say, okay, we'll go and pick up and approach people early in these places, because we know every day or every week people are going to be here doing this. Okay? So what can we do if we want to understand the risk which in a particular individual who has self-harmed in any of those places, let's say in school, in an emergency room? What do we do?
Listen.
Pardon? Okay.
Listen.
So you listen, and what do you listen for?
What people are telling you. What they feel they need.
And what's the what is the most immediate thing we should be listening for?
Pardon?
What's the most immediate thing we should be listening for?
Risk of suicide.
Risk. What are the things which are pushing them to risk? We don't have to understand everything about their life. We first have to understand at that point, how can we reduce the risk tomorrow, day after, next week? Okay. So training people in good risk assessments. Every person who self-harms must get, it should be a standard, must get a good mental health assessment and risk assessment. And that's what the standards became in Europe. And in fact, in emergency rooms, there are nurses who only do that. And they become really good at it. I've seen them. They can walk in and talk to a person, and within minutes they know how, because they just have that kind of experience and how they can come across, what they can talk about, etc. So good risk assessment. Everyone who self-harms deserves a good risk assessment. What can we do to understand the mental and psychosocial issues around it? That's going on to your question. A good mental health assessment. Okay. A good risk assessment, a good mental health assessment, because we don't want to miss those factors. And mental health assessment also assesses other psychosocial needs like housing, finance, relationships, etc. So how do we get them to a really dedicated team for self-harm or suicide reduction without going through waiting list? Waiting list is the bane of our life, isn't it, in Canada? We actually just accept being in waiting list. So dedicated service to actually cut through waiting lists, so we intervene for the self-harm. Okay. How do we develop such a team? Because it's not just about being available. It is a lot of skills to develop in people to work with. It's hard for mental health professionals as well to work with this group. It's very hard. It's very taxing. And every time when something serious happens, it stays with you for a long. I mean, I can recall that I've been doing therapy and other work for quite some time, but that was the only time I actually lost sleep when I started working in this area. So it's hard. How do we train people? How do we develop such a team? Well, I'll give you the answer. The develop is that we have to have very intense and high fidelity training. Something which I'm actually shouting from rooftops in every province that I'm working in Canada, that we just cannot assume what is happening inside rooms between patients and clients, and we have to record and look at and train people specifically to work. So a lot of my work, for instance, in Nova Scotia has been going through hours and hours of recording of people, talking to people, and hearing what's happening in that interaction. So actually developing those, it can be done in a very short period of time. So I think we have to say, we can blame the system, absolutely. System is actually already underfunded. There are lots of flaws in how we think. For instance, the system is not a psychiatrist. The system is a whole, I mean, not because I don't want psychiatrists to be blamed and I'm a psychiatrist. The fact is we have to think of ourselves as team. The moment I hear psychiatrists, I'm thinking, okay, but what about the whole mental health team? This has to be a team approach. So that's number one. We should look at running some successful pilots, because that's what's going to be convincing. You know what, the Ottawa Citizen Rights is going to be more effective than me giving hundreds of talks. Because so we should be doing successful pilots. It doesn't have to be a lot of money, but it has to be a lot of intensity of training. I can tell you straight away, and I have colleagues from Nova Scotia who just left. In Nova Scotia, they set up the entire province-wide DBT intervention for $200,000 by writing to Bell, Let's Talk. So it can be done. And I know many of my trainees went and became trained, and we set up programs. We didn't hire a single new person. Okay. So it can be done. We just have to have the will and some philanthropic donors to get started somewhere. So that's it. It can be done. Doesn't need huge amounts of money. We just have to show some successes. What happens when the treatment program is complete? People go for DBT, people go for transfer. What happens when they're complete? Well, the work is not over yet. That's where the care navigator has to continue helping person develop other things, because these treatments reduce the risk. They don't necessarily solve everything else which people are struggling with. So we need to have a navigator. So by the way, I mean, the countries which I've worked in, they're not spending more money in healthcare than Canada. So European countries are not spending substantially more healthcare per head of population than Canada. We just have to restructure how we spend that money, right? So that's what. So the care navigator, in my mind, is an excellent investment. We do have good care navigators. They are in the programs like assertive community teams, which is mainly serves people with psychosis. That model is great. They're good care navigators. We have good care navigators in organizations like CMHA, and I'm sure there are other organizations. So we are aware of these models. It is available. We just have to invest more on that, okay? And do less of something else. These are important documents you might want to read if you want to delve more. Now, clearly there's a lot more literature, but these documents summarize some very, very key things. In particularly the Preventing Suicide document 2016 is an excellent document, although the context is a little bit more England, but in general it covers many, many good ideas and gives examples of ways in which interventions can be done. I thought of listing all the resources, and then thanks to the Royal, just go here. It has all the resources, and it's a page-long resources of every helpline, every number of documents, whatever you need is there at the Royal website on suicide prevention. Okay. And with that, I've come to an end of my presentation, I think, and I hope